arthritis. And I think what I'm going to say is I'm going to show you a few things about how to diagnose midfoot arthritis, look at the structure of the foot, which part of the foot which you mean is midfoot, and then deal with the management. Basically, the foot structure has 26 bones, of which 7 are the tarsal bones, 5 metatarsals, and 14 phalanges. The midfoot anatomy is basically composed of the Lisfranc joint in the front and the Chopard's joint. And the navicle is married to 3 cuneiforms, and the cuboid is married to 2 metatarsals. The skeletal design of the foot is basically you have the first metatarsal cuneiform, which is the rigid medial column, the second and the third metatarsal cuneiform, which is the rigid middle column, and the fourth and fifth metatarsal cuneiform, which is the mobile lateral column. And they have certain amount of range of motion, which is very limited. Then you have the intercuneiform, the navicular cuneiform, and the metatarsal cuboid joints. There's a certain anatomical peculiarity of the midfoot in terms of its ligaments. The midfoot joints are very small. They have a very limited motion. The ligament structure is extremely complex. Generally, the dorsal ligaments are the weaker ones, and you have the long second ray. Now, the causes of midfoot arthritis, you have the primary idiopathic, which could be because of the plano-valgus foot or the long second metatarsal, inflammatory, in which one of the unique things is that only 62% show Xray changes and 27% are symptomatic. In post-traumatic, you have the Lisfranc's injury, which can lead to midfoot arthritis, and you could have the Charcot's arthropathy, gout, and sometimes the secondary causes. The Bony interlock, which is a very unique part of the midfoot, is formed because of the trapezoidal metatarsal basis and the recessed medial cuneiform. This is a very unique design which gives an intrinsic stability to the foot structure, and the wedge-shaped cuneiforms. And the key joint is the recessed second metatarsal, which is usually injured during the Lisfranc injury. In the ligamentous structure, you have the dorsal ligaments, the interosseous ligaments, the volar ligaments, the plantar fascia, the peroneus longus, the FHL, and the erector hallucis, which provides the musculo-ligamentous stability to the foot. Now, in the interosseous ligaments, all the metatarsals are linked to each other, except the first and the second. And you have the volar, the Lisfranc ligament is actually a volar structure, which connects the medial cuneiform to the second metatarsal base. A little bit of the midfoot biomechanics. What is unique about it? It is less mobile than the hind foot. It is like a link beam between the stable hind foot and the flexible forefoot, an average range of 0.6 to 11.1 degree. The maximal motion is at the fourth and fifth tarsometatarsal joint, but the maximum loading occurs at the second and third metatarsal joint. In the demographics, the post-traumatic midfoot arthritis forms about 25%. Atraumatic have usually late presentations. One of the unique things that is seen is most of these patients tend to have a long second metatarsal, which in some way contributes to the problem. There's a ratio of 4.5 to 1 female to male, so more females. And the second and the third TMT is the most involved. So how do you pick up these lesions? I mean, what does the patient complain of? Generally, the patient with the midfoot arthritis will say, I'm getting an aching over my midfoot, a startup pain. You know, when they wake up in the morning, when they first touch the foot down to the floor, there's a pain for a few minutes. They complain of pain climbing upstairs. There's sometimes cramping calf pain because of the tight TA. The shoe wear is usually a painful thing. They constrict to tight shoes. They are very uncomfortable. The foot is usually turned outwards, and toe walking is painful. So what do you observe as a clinician? You look at the foot is usually a rigid flat foot. There's a secondary hallux valgus sometimes, a rocker bottom type of a foot in an advanced stage. You'll find that the tibialis posterior is usually inflamed. There will be a dorsal bossing. You can feel that the patient has like a bump on the top, and the shoe tends to wear out laterally. In your clinical findings, you can have a tender MCJ, which you do by the piano key test, painful pronation abduction, and abduction dorsiflexion deformity of the forefoot. There's a midfoot collapse, a tight TA, a hindfoot valgus in a very late case, and sometimes you could get neuritic symptoms because of the impingement caused by the dorsal bump, by the deep peroneal nerve, and the extensor tendinitis. Now about the pathomechanics, what happens in midfoot? Basically, there is a metatarsal dorsiflexion and calcaneal eversion, which tends to stiffen the foot. There's a forefoot abduction, a midfoot pronation, and the medial column undergoes a dorsiflexion. and also a lateral column shortening. Now all these things are issues are important because these are the ones you need to correct when you're doing your surgery. Do not forget to examine the tibialis posterior and the TA and the peroneal tendons because they go under contracture as the condition progresses. In the Xray evaluation, you look at the AP view for the medial column, the oblique view for the third to fifth column, and the lateral view you look for the osteophytes and the dorsal bossing, you look for the joint irregularity, loss of the Meary's line. You could pick up the changes early if you do a CT scan, and any tender spots you could inject fluoroscope guided injections to find out the source of pain. In the conservative treatment, you could use NSAIDs, local corticosteroid injections, modify their activities, shoe orthotic changes, and it does help. But eventually, and the range that of orthotics that you could use could be a custom mold, a carbon fiber plate, or any of the off-the-shelf orthotics. But at some point of time, these things will stop working. So then comes to the surgical principles. Once you have decided that this patient needs surgery, there are a few things that you need to understand. You can fuse the medial and the middle columns, and that can be done in situ fusion with dowel grafts or slot grafts. The whole principle is you resect, you realign, and then you arthrodose. Generally, you try to fuse it as it is, the results are inferior. You could use autogenous iliac grafts. Try and include intercuneiform arthrodesis if in doubt, definitely improves the results. Avoid only dorsal plates. Try and add interfragment compression using screws. And tendon interposition arthroplasty is only for the lateral column. So the lateral column being mobile would not tolerate fusion as much better than the medial column. And the Glissans principles of arthrodesis: remove all interposing soft tissues, accurate fitting of the fusion surfaces, optimal anatomical alignment. It is extremely important to restore back what the foot looked like. Don't try not to fuse it as it is. Proceed from proximal to distal and medial to lateral, rigid fixation till fusion, and try and preserve as much as blood supply. In the realignment, you have to adduct and plantar flex the first, second, and third ray with the hind foot, and correct the deformity if it is more than 15 degrees or more than 2 mm displacement. Fusion of the first ray via the first tarsometatarsal joint. Fusion of the second and third ray via the navicular-cuneiform and intercuneiform joints. Try and achieve the varus and the plantar flexion of the first ray. It's extremely important to restore that structure. Might need a bone block if you want to correct deformities, and use a low threshold to use plates. Do not forget that doing these additional procedures would improve the final outcome. Tail lengthening, hind foot realignment osteotomies, and a cotton osteotomy on the medial side. Now, in the medial column surgery, ORIF with fusion with lag screws showed an excellent 69% results in one of the Sangarazan's 16 patients. Medial plate realignment and fusion, 77% results. Plantar plating is more rigid and stable, but it can be done only on the medial side. In situ fusion and post reduction lag screws did improve the score from 44 to 78 in 32 patients by Commenda et al. And you could use the combination of plating, staples, and lag screws and add bone graft to improve your union. In the lateral column surgery, it's basically to achieve stability with a little bit of mobility, because that's how the lateral column is naturally. But you want to maintain the length. The whole idea is to maintain the length yet maintain mobility, so that it allows a little bit of gait accommodation. In the lateral column, again, you could use peroneus osseous, a ceramic sphere, or a temporary pin fixations to achieve that purpose. But it's effectively a salvage surgery. In the outcomes, they are better in the degenerative group, better in the well-aligned fit. So again, here the point is realign and then fuse, and the scores definitely tend to improve. You have to be careful about smokers, diabetics, and Charcots. Could use PRP, demineralized bone, and EMF to improve your fusion rates. Pain relief is never complete, yet it does achieve a reasonable amount of relief. But the patient usually never returns to their prolonged standing jobs. To recollect, you identify the cause of the midfoot arthritis, confirm the location by doing your injections. Trial of conservative is extremely important before surgery. Arthrodesis of the stable column, arthroplasty of the mobile column, correction of the deformity before arthrodesis gives better outcome, and you address the associated deformities. Thank you. And at this point, I would like to invite you for the Indo-US mid-year course. The dates are not yet confirmed, but somewhere in June last week, which will be after the Bangalore course, and I would like to invite all of you to go and enjoy the hospitality. Thank you.